Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This patient is a hearing aid wearer. They're actually one of my clients, and during their 6-monthly routine hearing aid service, they reported that they weren't hearing as well through this right ear, and upon inspection, as you can see, this patient's got this thick layer of crusted dead skin with some more mushy discharge debris on the underside of that. Most likely, as you can see there, you got that crusty outer layer inside. It's a bit mushy. That's probably just the sweat and humidity, and it could also be some bacteria there as well, creating that consistency of dead skin. And they have got a very, very narrow ear canal and quite a bendy ear canal. And as we approach the eardrum, there's a pronounced narrowing. You may be able to see that on screen now. Either side of the suction tube, you've got the ear canal wall that protrudes immediately inwards, and then it widens again. And I'm having to use the fine end suction probe for several reasons. And when we approach close to the eardrum, the fine end is a better suited instrument, because if we do come in contact with the eardrum, it's less likely to cause trauma. Also, the fine end gives you more precision. So when you're working on the eardrum, it's of course a lot more delicate procedure where you need more precision, and it's a bit less noisy, which helps because microsuction can be noisy, and with the full Zollner suction probe up against the eardrum, it may not be a very pleasant experience for the patient. The downside with the fine end is sometimes it's just not powerful enough because it's got a small internal diameter, and it can get blocked easily as well because of the smaller internal radius diameter. I've just put some softening drops in there just to loosen this dead skin. So the reason why this is a chronic condition, they have to have the dead skin peeled away off the eardrum, I would say annually, and they've just got a very high turnover of dead skin on the eardrum. So the outer layer of the eardrum is made up of the same skin that lines the inner 2/3 of the ear canals, the epidermis layer. And that skin, it gets replaced by another layer of skin, and that skin then dies and it sheds, and it should naturally migrate. But in this case, the skin, it's just a high turnover of dead skin, and this skin's not able to fully migrate. In part, it could be due to the patient's narrow ear canal adjacent to the eardrum, the isthmus region. So the skin manages to come away from the drum, and it gets trapped in that medial pocket where the ear canal's widen and it narrows. And then that skin, the outer layer, oxidizes, it can become crusty, and the fresher layer of skin that's sitting in between the eardrum and that crusted layer, because of all the sweat and humidity, and it could also be some bacteria, fungi as well, it's making it softer and mushy. So once we peel this away, the eardrum looks nice and healthy. Now, they have many moons ago suffered from a perforation anteriorly. So when we say anteriorly, we mean to the front part of the eardrum. So in the case of this, their right ear, to the right hand side, about 3 or 4 o'clock. So that part of the eardrum we've got to be really gentle with. That part of the eardrum is always retracted. It's pulled inwards because of negative middle ear pressure. Behind the eardrum, we have the middle ear cavity. And the middle ear cavity should be full of air, and the air pressure behind the eardrum should be equal to the air pressure in front of the eardrum, so in the ear canal. When the air pressure is equal either side of the eardrum, that's when you hear the best. That's when the eardrum is most mobile. So what regulates the air pressure behind the eardrum is a tube called the eustachian tube. It's a narrow orifice that connects the middle ear to the back of the nose, the nasopharynx. And at normal resting state, that eustachian tube is closed, it's shut at the back of the nose. But during brief moments of yawning, swallowing, chewing, without us even noticing, the muscles either side of the eustachian tube, they contract, causing the eustachian tube to open. When the eustachian tube is open, the air pressure can equalize itself. So if the air pressure behind the eardrum is below the air pressure in the atmosphere, air can fill up the middle ear to equalize it. Or if there's excessive air behind the eardrum in comparison to in front of the eardrum, the eustachian tube allows some air to escape. But if that eustachian tube fails to open when it should, and that could be due to nasal congestion, so if you've got cold, cough, hay fever, it's any mucus inflammation, It could be a physical obstruction, so a polyp, for example, a deviated septum. It could be sinusitis, rhinitis, so it could be infection there as well. Or the muscles themselves can be paralysed, so when they should open and when they should contract, they don't. Or some people are just born with an anatomically narrow eustachian tube. Air fails to enter the middle ear, which means they have negative middle ear pressure. So the air pressure behind the eardrum is below the air pressure in the atmosphere, and the remaining air in the middle ear then gets absorbed by all the cells in the middle ear, which leaves the middle ear vacant of air. It's like a vacuum, and the eardrum gets sucked in, it gets cupped inwards. And where we are now, this is where I believe the patient, they advised many years ago they had a perforation since healed. So we're going to be very gentle here, because when you, because the eardrum is sucked in, it's normally the thinnest part of the eardrum that gets sucked in. So normally the top of the eardrum, the attic region, is susceptible to getting sucked in, and that's because, so we'll just go explain the eardrum anatomy. So the eardrum has got 3 layers. The outermost layer, as I mentioned at the beginning of the video, it's made of the same skin that lines the inner 2/3 of the ear canal. The innermost layer of the eardrum, which is not visible to us, that's made up of the mucosa. So the mucosa is the skin that lines the middle ear, and it's similar to the skin, not exactly the same, but it's similar to the skin that lines the inside of our nose. So it's secretory, it can produce mucus. And then the eardrum also has a middle membrane made up of fibrous tissue. Now, the fibrous tissue in the top part of the eardrum, the attic region, the fibrous tissue is more diffuse, whereas in the main body of the eardrum, what we call the pars tensor, they're radially aligned, so it's got more structure. So the top part of the eardrum is a bit more, bit less taut, a bit less stiff, so it's more flaccid, hence the name pars flaccida. We call the top part of the eardrum pars flaccida. So that part of the eardrum is more susceptible to getting sucked in. But if you've had a perforated eardrum, so all 3 membranes are perforated, if it heals, the mucosal layer can heal, so the innermost membrane. The outer layer, the epithelial layer, can also heal, but sometimes the middle fibrous layer doesn't. So instead of 3 membranes thick, the eardrum then becomes 2 membranes thick, and that section of the eardrum is obviously thinner, and if you've got negative middle ear pressure, that part of the eardrum can get pulled in. That's another plausible reason as to why the skin's failing to migrate, because if that part of the eardrum is sucked in, you've got a collection of dead skin in there, and it can get trapped. So this is the section I'm working on. I'm going to be really, really careful here. So there is going to be some residual skin remaining on the eardrum once we finish, but it's sometimes not possible to get all of it out. You've got to weigh up the risk-benefit ratio. So by trying to get every little speck, everything that I felt comfortable trying to remove, I did certainly go for. But you're always in the risk of potentially perforating the eardrum, which we don't want to do. Now the eardrum's a lot more. It's got a lot more strength than I initially thought was the case. So as an audiologist in the UK, during our training, and this may change, and hopefully it does change moving forwards, earwax removal is not a skill that audiologists were taught during their training. So at university, we never underwent any modules or training to remove earwax. Earwax was always removed in the UK in primary care by GPs or primary nurses using ear irrigation, and prior to that ear syringing. And then the more complex cases, or where you can't have water flushed in your ear, these patients will be referred to see an ENT specialist or ENT nurse at the hospital. Now, there were some audiologists a decade or 2 ago performing private earwax removal using microsuction, but it wasn't the gold standard, it wasn't the norm. Although obviously we learn about the ear anatomy and the eardrum anatomy, when I first performed the earwax removal and I went towards the eardrum, it was extremely nerve-wracking, to say the least, because you're just so worried. It was the last thing you would do is perforate the eardrum, but I soon came to realise the eardrum's a lot more it's got a lot more. It's not as fragile as I thought. Now that doesn't mean no, I say that in a way. I want to just almost like a disclaimer. That doesn't mean I don't want anyone poking in their ears thinking the eardrum won't perforate. It definitely can perforate, but it's just a lot more rigid, and it's a lot more elasticity than I gave it credit for. So just still be careful. It's very easily perforated, but yeah, I was pleasantly surprised by that. So it's just some residual skin at the roof of the ear canal. Again, it's not going to cause any problems, but kind of know this patient's going to have this procedure performed again and again. So if I can just remove a bit without risking any or inflicting any trauma in the ear canal, it just might last a bit longer for the patient before the next time they have to remove. The patient's very still. They weren't experiencing any discomfort. I was asking throughout the procedure if they're okay, because these are probably the more delicate procedures are the ones that there's more potential of causing a bit of trauma or causing a bit of discomfort to the patient, because we're working near the eardrum, or in this case actually on the physical eardrum. In addition, we're on the bony part of the ear canal. So just a little bit left at about 2 o'clock. I'm just going to hover over, see if I can remove that. There's a little bit of dead skin also crusted on the handle of malleus itself, so the hammer bone. I'm going to try and see if I can get that out as well, but I wasn't able to do that. I was having to glide the sucker physically over it, and it wasn't budging, so we just left that. But the patient could hear a lot better. They're really pleased. You can see the fine end, how I've just curled it. I've just bent it at the tip. And the reason for that is to help avoid contact with the front part of the ear canal. So if that little kink wasn't there, that fine end would make contact with the front part of the ear canal, and it will graze it and it'll be a bit uncomfortable. So I'm just trying to curl around that. Now there is a bit of granulation tissue at the base of the ear canal near the eardrum, so I have just written to the GP they can get some treatment for that, and just recommended some acetic acid spray in the meantime as well. You can see just at 6 o'clock near the eardrum some granulation tissue there. So that's how the patient attended. This is how they left. So a lot better. I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.